Hello everyone, I'm Dr. Rohan Khandelwal, your Marrow SS General Surgery faculty. I'll be talking about the NEET SS General Surgery questions in this video. Now, it was a very strange exam because for every subspecialty, there was a separate group of general surgery questions. So, somebody in pediatric surgery got a lot of questions from GI, whereas somebody in GI surgery got a lot of questions from pediatric surgery in the general surgery component. So, what that has led to is a huge question pool of questions and explanations. So, I'll try to cover all of them. And it would be my sincere request that you go through these questions. So, with this huge question set, they can ask similar questions or similar topics in the upcoming exams. So, you should go through these questions in detail. Now, let's start with the questions. Majority of them were very straightforward questions directly from the videos. There were a few questions which were outside the videos. I will mention those questions to you as well. But almost 85 to 90% questions were covered in the Marrow General Surgery videos. The first question, I think so, this is a hot topic both in PG and in SS. This was about hypertrophic pyloric stenosis. There is a 4-week-old baby who is brought to the emergency with projectile non-bilious vomiting. Examination shows visible gastric peristalsis. So, we know the diagnosis is idiopathic hypertrophic pyloric stenosis. Right, idiopathic hypertrophic pyloric stenosis, and the expected metabolic abnormality is hypokalemic, hypochloremic, metabolic alkalosis with paradoxical aciduria. So, this is a very common question which is asked. So, we know idiopathic hypertrophic pyloric stenosis is diagnosed using an ultrasound. This is a typical metabolic abnormality, and first you have to correct the metabolic abnormality and then carry out surgery for the patient. The metabolic abnormality is hypokalemic, hypochloremic metabolic alkalosis with paradoxical aciduria. The fluid of choice is N/2 NS with dextrose and KCl. And you know that KCl should be added, or potassium should be added, when kidney function test is normal, or when KFT recovers, that's when you add potassium in these patients. So, usually affects male patients, usually firstborn male children, between 4 to 6 more times than females. This is an important thing which you should know. There are reduced levels of neuronal nitric oxide synthase have been found in these patients. So, this is very, very important. This is an update. There are reduced levels of neuronal nitric oxide synthase in these patients, and the associations are trisomy 18, Apert syndrome, or Cornelia de Lange syndrome. Also, maternal erythromycin intake has also been linked with idiopathic hypertrophic pyloric stenosis. So, this is another thing which you should know about. Now, another question which was asked was, which of the following combinations of IV fluids would be ideal for resuscitation of a child with idiopathic hypertrophic pyloric stenosis? So, like I just told you, it is N/2 normal saline with dextrose with potassium. So, it is going to be 5% dextrose, 0.45% saline because it is N/2 with 20 milliequivalents of potassium. So, there were 2 questions based on this topic, and again one question was asked in one subset, the other one was asked in another subset. So, what you can see are the topics were remaining the same. I have already told you that potassium should be added only when the kidney function recovers. What is the T stage in gallbladder cancer? If there is a growth in the fundus which is infiltrating the serosa without involvement of liver, right, without involvement of liver. So, this is T3. You can see this is the TNM staging for gallbladder cancer. Gallbladder cancer TNM staging is important. Lots of questions have been asked regarding this. The most important is T1, T1A is when it involves the lamina propria, and T1B is when it invades the muscle layer. So why is this important? If the patient has been diagnosed with T1A, no further surgery is required. No further surgery. Supposing the patient underwent a lab chole and it turned out to be a T1A gallbladder cancer, no further surgery is required in this patient. But if it is a T1B disease that is involving the muscle layer, or it is T2 which invades the perimuscular connective tissue, and there is no extension into the serosa, that is T1B or T2, in these patients you will need to do an extended cholecystectomy, where you have to then remove segments 4B and 5 of the liver, and you have to clear the lymph nodes along the hepatoduodenal ligament as well. T3 is when it perforates the serosa or directly invades the liver, one of them, or an adjacent structure like stomach, duodenum, colon, pancreas or extrahepatic sites. T4 is when it invades into the main portal vein or the hepatic artery or multiple extrahepatic structures, that is T4. So you should know the TNM stagings, the T stage specifically for gallbladder cancer. So Child-Pugh score is frequently asked in the exam, and they're asking what will be the Child-Pugh score for a patient who has cirrhosis, who is conscious, oriented with moderate ascites. INR is 1.1, bilirubin is 2 and albumin is 2.2. So you need to know all the parameters for the Child-Pugh score. Here the Child-Pugh score is going to be 9. It will turn out to be 9, and I'll just show you how it is 9. So because the patient is conscious and oriented, encephalopathy score is 1. There's mild to moderate ascites, so the score is 2. Bilirubin was 2, so it is between 2 to 3, it is going to be 2, the score. Albumin was less than 2.8, so the score is going to be 3. And prothrombin time or INR was 1.1, so the score is going to be 1. And if you total this up, this turns out to be 9. You should also know that Child-Pugh A score is between 5 to 6, B is 7 to 9 and C is 10 to 15. So this patient falls under Child-Pugh class B. So all the parameters regarding the Child-Pugh score you should remember for the exam. Another question was regarding pancreatitis. There was a patient with acute pancreatitis who presents with a worsening of clinical picture, right? So the clinical picture is worsening day by day. CT shows infected necrosis. Infected necrosis, when you do the CT, you will see a collection, and if you see air bubbles inside it, or if the TLC is increasing, you can get a hint that it is infected necrosis, and there is peripancreatic collection. So when you have infected necrosis, you have to drain that collection, and in infected collections you usually carry out percutaneous drainage. So we put in a pigtail catheter and we drain out this collection. Another question related to a score, this was, which of the following is an indication for endoscopic management in bleeding peptic ulcer? So again, upper GI hemorrhage, whether you talk about general surgery or GI surgery, there are at least 2 questions, 1 to 2 questions from upper GI hemorrhage. One might be related to variceal bleeding and one is usually related to non-variceal or the protocol in the management of these patients. So the indication, if there are clots at the base, no. Clots in the stomach, no. Visible vessel over ulcer base, this, yes, is an indication where you need to cauterize that vessel, otherwise there is a high risk of rebleeding. This is based on the Forest classification. This, you know, is the Forest classification. This Forest classification is an endoscopic classification which tells us about the risk of rebleeding. It is an endoscopic classification which tells us about the risk of rebleeding. That is what we get to know from the Forest classification. Class 1A is when you have a spurting hemorrhage or oozing hemorrhage. 2A is non-bleeding visible vessel. These 3 patients have high risk of rebleeding. 2B is an adherent clot. 2C is flat pigmented spot, and 3 is a clean ulcer base. So, this forest classification you need to remember for the exam. This next question was again a repeat of the NEET SS General Surgery portion. There is a patient with dyspepsia. Upper GI endoscopy and biopsy revealed a MALT. MALT, you know, is mucosal associated lymphoid tissue tumor. Mucosal associated lymphoid tissue tumor is MALT. So, you have a low grade maltoma. What is the next line of management? So, we know in maltomas are caused by H. pylori, and if it is a low grade maltoma, these low grade maltomas respond to H. pylori eradication therapy. So, the answer here will be antibiotics, that is H. pylori eradication therapy. So, low grade maltoma, H. pylori eradication therapy. High grade maltoma, we give chemotherapy like we will give in lymphoma in these patients. So, this was a question which was bit difficult. There was a Zygos preserving repair of tracheoesophageal fistula is done in for which of the following reasons. So, when you are repairing a tracheoesophageal fistula, majority of the times a Zygos vein was being ligated, right, to approach the fistula. But a Zygos preserving is done to decongest the anastomosis, and what they have seen is that if you preserve the azygos vein, then there is less edema in the anastomosis and the chances of anastomotic leak are less. So, to decongest the anastomosis, reduce the risk of anastomotic leak, we do an azygos preserving repair. So, this I have already mentioned, this is for decongestion of anastomosis. Which of the following maneuver is shown in this picture? Again, these maneuvers, cattle brush and Mattox procedures, are frequently asked in the exam. This, you know, is a cattle brush maneuver, which is right medial visceral rotation, So, right medial visceral rotation, you can see that the ascending colon is mobilized medially, right? The ascending colon is mobilized medially. So, once I do this, I am exposing the retroperitoneum, and what is on the right side towards the right is the IVC. So, what gets exposed here? You can see here the IVC gets exposed in right medial visceral rotation. So, supposing you are operating a patient with a renal cell carcinoma where you have to take control of the IVC or the renal vein, there you will carry out a cattle brush maneuver and you can expose the IVC. The opposite of this is known as Mattox maneuver. Mattox maneuver is left medial visceral rotation. And left medial visceral rotation basically means that the descending colon is mobilized medially, and again you expose the retroperitoneal space and this exposes the aorta, and Mattox is done when you are operating a patient with abdominal aortic aneurysm. You will carry out a Mattox maneuver to expose the aorta. Cockerization, you know, is mobilization of the duodenum, right. So, these maneuvers you should know for the exam. So, this one here is Mattox, which is left medial visceral rotation, and this one is cattle brush, which I just explained to you. A newborn girl was brought with features of obstruction and a single opening was seen in the perineum. What is the diagnosis? So, this was a question related to pediatric surgery, and I think so it was a very easy question. The whole point where they have said that there is a single opening, right. Single opening means that the fecal passage and the urinary passage are common and the reproductive passage are common. So, there is a single opening. This single opening is known as a cloacal opening. You know that during embryogenesis, the fecal passage and the urinary and the urogenital passage, they get separated, right. But if they do not get separated, it is going to give rise to a persistent cloaca. So, you can see here that there is the rectum, the uterine and the bladder opening are common, and this common opening is known as a cloacal opening, and this is classified as one of the anorectal abnormalities, anorectal defects which are there. So again, anorectal abnormalities can be high, intermediate or low. High abnormalities are usually associated with a fistula. High are usually associated with fistula. So you have anorectal agenesis with a rectovesical fistula. Rectal atresia can be there. The miscellaneous abnormality, especially in females, is a persistent cloacal abnormality, which I have just explained, where there is a common passage for the fecal matter, the reproductive passage and the urinary passage is common. That is known as a cloacal opening. There was another question related to anorectal malformations. A newborn was brought with abdominal distension on the 3rd day of life. He hasn't passed meconium since birth, and examination showed an absent anal orifice. Now, you usually know whenever the child is born, the pediatrician examines the anal opening, whether the anal opening is patent or not. In this case, it wasn't examined and there's an absent anal orifice. So, I've just explained to you this is anorectal malformation, and whenever you get a child with anorectal malformation, the first thing which we do is a cross table X-ray, right? First thing which we will do is a cross table X-ray, because that will show till what level is the gas reaching or the air shadow is reaching, right? Earlier we used to do invertograms as well, but the investigation of choice for anorectal malformations these days is a contrast MRI. MRI gives the best anatomical delineation in patients with anorectal malformations. So, if you have a newborn male where you are suspecting anorectal malformation, this is from Sebastian. We are going to rule out other metabolic abnormalities, rule out other congenital abnormalities, rule out other congenital abnormalities. We do a cross table film, right, and based on the problem we proceed further in these patients. If it is a high defect, we usually do a colostomy and then the definitive surgery is done in the second stage. But if it is a low abnormality, then a single stage definitive surgical procedure can be done. 8-year-old child was brought with a well-defined mass in the epigastric region. He had an accidental fall while playing 6 months back and sustained injury to his upper abdomen. What will be the first line of differential diagnosis which you would think? This I feel was, I think so, 6 weeks and not 6 months. And this is a typical history of a pseudopancreatic cyst, right? So, hemangioma unlikely to present like this. Peritoneal inclusion cyst and gastric duplication cyst will also not present like this. You need to know that the most common cause of pancreatitis in children, is trauma, right? So, trauma is the most common cause of pancreatitis, and post-trauma, a pseudopancreatic cyst can develop in the epigastrium, and that is the history which has been presented here. A 4-year-old child presents with history of constipation for 6 months. He passed stools within 24 hours of birth and has normal psychosomatic development. What is the likely diagnosis? So, when you encounter such a patient, of course, your mind will start thinking towards Hirschsprung's disease, towards hypothyroidism. But this patient passed meconium within 24 hours. So, there was no delayed passage of meconium and there are no psychosomatic features. So, this rules out Hirschsprung's and hypothyroidism, and the correct answer here is functional constipation. So, functional constipation is a common childhood problem, and it is when there is no underlying organic cause. It can be seen in children 1 year or older than that, particularly common again preschool age children. Functional constipation, there will be difficult or infrequent bowel movements and there is deviation from normal frequency. Painful defecation or passage of hard stools. It is not caused by any underlying systemic cause or anatomic defect, right. So, usually underlying systemic cause or anatomical defects would be missing. Hypothyroidism will be associated with other features of hypothyroidism, and Hirschsprung's also. Patients can have Down syndrome, and also there is delayed passage of meconium in Hirschsprung's, which wasn't the case in this question. This was again a very interesting question. They had shown an image of a patient undergoing surgery for gastroesophageal reflux disease, and the surgeon was demonstrating his assistant this maneuver. Now, you know that for gastroesophageal reflux disease, we carry out fundoplication. What we carry out is fundoplication, right? And one of the steps in fundoplication is when you take the stomach behind the esophagus, to wrap the esophagus, this maneuver, when you are doing this maneuver, you are mobilizing the stomach around the esophagus, this is known as the shoe shine maneuver. This is known as the shoe shine maneuver. Okay. Pringle's maneuver, you know, is when you press the hepatic pedicle, when you compress the hepatic pedicle at the foramen of Winslow, hepatic pedicle at foramen of Winslow. And this is usually done when there is hepatic trauma. It helps in two ways. A, it can temporarily reduce the bleeding, and you also get to know what is the source of bleeding in patients with hepatic trauma by doing the Pringle's maneuver. So, this is after pressure, we do Pringles and packing in a patient with liver trauma. What is the shunt created between the superior mesenteric vein and the portal vein in case of extrahepatic portal venous obstruction known as? So, this shunt is known as the Rex shunt, which is created between the superior mesenteric vein and the portal vein in patients with extrahepatic portal venous obstruction. Again, I told you that patients, one of the variceal causes and one non-variceal question is usually there in the exam. So, this was the one which was related to variceal causes. So, this is the Rex shunt. Rex shunt, I just told you, is between the superior mesenteric vein and the portal vein. You can see here, this is the meso-Rex shunt between the superior mesenteric and the portal vein. In another subset of general surgery questions, there was another question related to shunts, and this was that for the treatment of portal hypertension, which of these is a selective shunt? So, Rex, I just told you, is a non-selective shunt, right? Portocaval is also non-selective, mesocaval is also non-selective. The correct answer is surface shunt. And you know, selective shunts are, and you have non-selective shunts. So, non-selective shunts, they shunt both bowel blood and splenic blood, whereas selective shunt only shunt out splenic blood. And the advantage is that non-selective shunts, because bowel blood is also being shunted, there is a risk of encephalopathy. In selective shunts, encephalopathy is uncommon because you are only shunting out the splenic blood and not the bowel blood. So, this is something which you should know about. These are the various shunts, you know, that distal splenorenal, also known as Warren shunt, Inokuchi shunt, which is left gastric shunt. These two are also selective shunts. These are also selective shunts like the surface shunt. TIPS is also an example. TIPS is transjugular intrahepatic portosystemic shunt. This is also an example of a non-selective shunt. Partial portosystemic shunts or surface shunt. It's a small diameter portocaval shunt. It partially decompresses the portal venous system. Hepatic portal flow is preserved. The drawback is that there is increased risk of thrombosis and there is increased recurrence of bleeding, but surface is a selective shunt. There were two questions regarding angles in laparoscopy, and I had covered this in the test and discussion for general surgery in the Marrow SS new test and discussion based on Subiston updates. I had covered these angles. So, in laparoscopy, what is the optimal manipulation angle to be maintained for good ergonomics? So, first you need to understand what is manipulation angle. Manipulation angle is the angle between the two instruments, that is manipulation angle. So, see here that manipulation angle is the angle between two instruments, and ideally this should be 60 degrees for good ergonomics. The azimuth angle is the angle between the endoscope, the camera, and the instrument, that is the azimuth angle, and the elevation angle is between the instrument and the horizontal plane, that is the elevation angle, right. So, the optimal manipulation angle for good ergonomics is 60 degrees in laparoscopy. I've already told you the definitions. These are the definitions. Manipulation angle is between the two working ports. Ideal is 60 degrees. Azimuth is between one instrument and the optical axis of the endoscope. Ideal azimuth angle is equal for active and assisting instruments. Elevation angle is the angle between the instrument and the horizontal plane. Ideally, this is also 60 degrees. So, you should know about these angles. They have been asked previously also, and this time also there were two questions. The second question was which has been correctly matched here, right. So, we just discussed the azimuth angle. We know that azimuth angle is between the endoscope and the instrument. The elevation angle is between the horizontal plane and the instrument, and the manipulation angle is between two instruments. This was another question which was a new question. The Mascagni node is encountered in which of the following surgery? So, Mascagni node is encountered during lap chole, and Mascagni node is nothing but the cystic lymph node of Lund. You know that you have the cystic lymph node of Lund in the Calitz triangle, and during lap chole we have to dissect the Calitz triangle. So, another name for this cystic lymph node of Lund is known as the Mascagni node, and this is also encountered during lap chole. Again, gallstone ileus, there was one question in the NEET SS exam as well regarding Rigler's triad and gallstone ileus, and again gallstone ileus was asked in the NEET SS exam as well. So, which of the following statements regarding gallstone ileus is false? The usual site of obstruction is terminal ileum. This is true. It is the last 2 feet of ileum. Rigler's triad is seen in 10 to 15% patients. This is false. It is almost in 30 to 35% patients. Pneumobilia is a ubiquitous finding because there is a fistula which is there between the gallbladder and duodenum. And gallstones can cause intermittent obstruction, yes, but it is a type of dynamic obstruction. Now, Rigler's triad, you know, Rigler's triad is 3 things are there. There is pneumobilia, there are features of small intestinal obstruction, and there is a radio-opaque shadow. There is a radio-opaque shadow in right lower quadrant. Radio-opaque shadow in the right lower quadrant. So, that is Rigler's triad. I have told you it is seen in almost 30 to 35% patients of gallstone ileus. It is secondary to a cholecystoduodenal fistula. Most common site is the terminal ileum. Regular stride I have already told you. And when a patient comes in emergency, our initial aim is to take care of the obstruction. Gallstone surgery and the fistula surgery is done as a second sitting later on, right. So, we do not usually address the gallbladder and the fistula in the same sitting as the emergency surgery. So, first we take care of the obstruction. So, in abdominal wall reconstruction, which of the following statements is not true? Quilt stitches help in reducing seroma collection. This is true. The density of perforators is maximum at a distance 3 centimeters from the umbilicus. This is false. They are majority in the periumbilical region. That is why we have to be careful while we are dissecting the periumbilical region. That is where majority of the perforators are there, and it is not beyond 3 centimeters, it is just in the periumbilical region. That is where majority of the perforators are there. Closed suction drains help in dealing with seromas. This is true. This is in fact one of the very few sites where drain insertion is recommended. Because drain insertion while doing component separation or abdominal wall closure for hernias it reduces the incidence of seromas. VAC dressings can help in closure after flap necrosis. This is also true. VAC is negative pressure dressing. VAC is negative pressure dressing, and minus 120 millimeters of mercury is the pressure which is exerted when we put a VAC dressing. How will you stage carcinoma stomach that has involved the subserosa with 5 positive regional nodes? So, you can see there were 2 questions, one from gallbladder cancer staging and one question was there from gastric cancer staging as well. So, the correct answer here is 3A, and this is the gastric cancer staging. It is stage 3A involving the subserosa with 5 positive regional nodes. After colonic malignancy resection, increased CEA is seen in which of the following situations? In all of the following situations except. So, we know that carcinoembryonic antigen is a tumor marker for CA colon, and we do the CEA before surgery and then we monitor the CEA values in the follow up period. If CEA is increasing, metastasis, it can indicate metastasis or recurrence, or if there is R1 resection, proper dip will not occur, proper reduction will not occur, right. So, this also is correct. So, the correct answer here is mucinous histology. Mucinous histology is the correct answer here. In mucinous histology, usually high pre-op CA values are there, high pre-op CA values are there, but there is good reduction after surgery. There is good reduction in mucinous histology after surgery. Usually patients with mucinous histology present with advanced stage, they have higher lymph node involvement, more invasion. So, mucinous in general, they will come with a higher stage disease, but there is good reduction in CA after surgery. So, CA will not rise in mucinous histology just like this. Which of the following below mentioned investigations cannot be done in a patient who has undergone bariatric surgery? He has undergone a mini bypass surgery. So, you know that Roux-en-Y gastric bypass or mini bypass. So, mini bypass is when there is a single anastomosis instead of Roux-en-Y where there were 2 anastomoses. Okay? But whether it is Roux-en-Y or mini gastric bypass, one of the drawbacks is that these patients cannot undergo an ERCP later on, right. That is one of the drawbacks, which is why if there are asymptomatic gallstones in a patient who is undergoing bariatric surgery, a Roux-en-Y or a mini gastric bypass, they recommend that you do a cholecystectomy in these patients. One of the reasons is because once you do this surgery, you will not be able to do ERCP. Why? Because if you see here, after reconstruction, if I put in the endoscope from here, I cannot reach the ample of Vater, I cannot reach it from here, right, which we can reach from here directly, we cannot go in from here. Similarly, after mini gastric bypass also, I cannot put in the endoscope here in the ample of Vater, so I cannot do an ERCP. So ERCP cannot be done in patients who've undergone a mini gastric bypass or Roux-en-Y gastrojejunostomy. SIRS and sepsis criteria are very important, asked in every exam. Which of the SIRS criteria includes all of the following parameters except? So, more than 10 band forms is there, respiratory rate more than 20 is there, temperature more than 38 is there, heart rate not more than 80, it should be more than 90 per minute. So, this is the correct answer. It should be more than 90, not more than 80. These are the SIRS criteria. SIRS stands for Systemic Inflammatory Response Syndrome, and this SIRS is mediated by IL-1, IL-6 and TNF alpha. If any of the two criteria are there, we call it SIRS. Temperature more than 36 or less than 36 or more than 38, pulse rate more than 90, respiratory rate more than 20 per minute, white blood cell count less than 4,000 or more than 12,000, or more than 10% band forms are present. QSOFA is one of the new criteria. This is quick sequential. Organ failure assessment score. QSOFA, this has also been asked many times, and QSOFA is respiratory rate more than 22, altered mental status or systolic BP less than equal to 100 millimeters of mercury. If any two criteria are met, we call QSOFA as positive. Again, hypovolemic or hemorrhagic shock is also a standard question in every exam. As per ATLS classification, what percentage is lost in class 2 shock? So, I have told you, just remember the scoring of a tennis game, right? So, 0 to 15 is class 1, 15 to 30 is class 2, 30 to 40 is class 3 and more than 40 is class 4. So, here it's going to be 15 to 30% is class 2 shock. So, this is the table I have just told you. Class 1 shock parameters don't change. Class 2 is 15 to 30%. This is known as compensated shock. So, in compensated shock, there will be increase in pulse rate, but systolic BP will be normal. So, increase in pulse rate will be there, but systolic BP is normal, that is compensated. Class 3 is decompensated. Class 3 is decompensated, that means that systolic BP falls for the first time. Systolic BP falls for first time in class 3 shock. This is also a very important question which you should know for the exam. Which of the following veins should not be cannulated in infants? So, if an infant is coming with dehydration, you want to put in a cannula. Which of the following veins will not be used? Internal jugular we can use, external jugular we can use scalp veins in infants as well. Proximal saphenous vein is not used. We can do intraosseous infusion in children as well, right? So, we won't use the proximal saphenous vein. The distal saphenous vein is used for venous cut downs. Degloving injury has been asked many times in the past, also been asked in the NEET PG exam. Degloving injury is avulsion of skin subcutaneous tissue from the underlying fascia. Avulsion of skin and subcutaneous fat from underlying fascia is known as degloving injury. This is what degloving injury looks like. You can see that the skin and the subcutaneous tissue has been avulsed from the underlying fascia. Again, Glasgow Coma score is also very important for the exam. You have a patient who sustained road traffic accident. He appears confused, opens his eyes in response to pain. So, E2, exhibits flexion response. So, M3, is there, and there's confused speech, right? So confused speech, V5 we know is normal speech, V4 is when the patient is confused. So V4, so this is 9 is the score here. Score is 9. You know the GCS criteria. You also know the new parameter is NT. So VNT, ENT and MNT. NT is non-testable. If you cannot test one of the criterias, you will write it as non-testable. You are going to mention it as non-testable. That is the new update which you should remember. Also, one more update is the GCS P score. So, what is the GCS P score? It is Glasgow Coma score minus the P score. P is pupillary response score. Pupil response score. This will give you the GCS P score. This gives you the GCS P score. So, if both the pupils are unreactive to light, the pupil reactivity score is 2. If one pupil is unreactive to light, the score is 1. And if neither of the pupil are unreactive to light or they are responding, then the score is 0. Now, the common sense question was that an industrial worker has severed his index finger in a machinery during work. How should the finger be transported to the hospital? Should we directly immerse it in antiseptic solution? No. Immersed in ice cold water? No. It should, is it wrapped in saline gauze within a plastic bag and sent in aseptic solution? No. It is wrapped in saline gauze, put within a plastic bag and then sent in an ice container. So, right, so direct contact should not be there. You first wrap it with the saline gauze, put it in a plastic bag, then put it in an ice container. When intraoperative air embolism is suspected, what is the ideal position in these patients? So, if there is air embolism, so usually approximately 100 cc of air is required to cause an air embolism, 50 to 100 cc of air, and in that condition what we need to do is left lateral and head down. Left lateral and head down position. Some people like to call it the Durant's position as well. Left lateral and head down. Basically, this prevents air from going into the pulmonary circulation, right? So, this position, left lateral head down, will prevent air from going into the pulmonary circulation. And if there is excess quantity of air, sometimes you can even aspirate it under ultrasound guidance. From the heart, you can aspirate the air. So, head injury scenarios are also frequently asked in the exam. This was a relatively straightforward question. In a patient with a motor vehicle accident, a 28-year-old girl got injured in the left temporal region. The rescue team found her unconscious with a dilated left pupil. She had a brief time back to consciousness on the way to the hospital, right? So, what is this period called? Consciousness, unconsciousness, again consciousness for a brief period. This is known as lucid interval. Now, you know that lucid interval can be seen in any head injury, but very common in patients with extradural hemorrhage. And the other indicators for extradural hemorrhage are a young patient and high velocity impact are also indicators for extradural hemorrhage. Subdural hemorrhage is more gradual, especially if it is chronic subdural hemorrhage. Chronic subdural hemorrhage, it will be seen in elderly patients, and the patient will have trivial trauma, and after trivial trauma, after a few days to weeks, the patient will lose consciousness, right? So, as compared to EDH, where there is a young patient, high velocity impact, and usually there is lucid interval. You can see a biconvex hemorrhage when you do an NCCT. NCCT is the investigation of choice in patients with head trauma. One more thing which you should know, the indications for craniotomy in EDH. This again is a new thing which is mentioned in the latest Bailey and in the ATLS manual. If the clot size is more than 30 cc, if there is a more than 5 millimeter midline shift, or if the thickness is more than 1.5 centimeters, these are also indications to carry out craniotomy in a patient with EDH. So, there's a couple of questions from breast. How is a sentinel lymph node sent for frozen section? So, you know, we remove sentinel lymph nodes during surgery. How do we send that sentinel lymph node to the pathologist? So, that sentinel lymph node is sent in a container which does not have saline and it does not have formalin, right? So, it's just sent like this in a container. You put the entire lymph node and you send it to the pathologist. You don't send it in saline and you don't send it in formalin. They had shown a mammogram, and in the mammogram they had shown microcalcification, diffuse microcalcification, clustered microcalcification was shown, and they had asked what is the most likely diagnosis. So, you know, this clustered microcalcification, it is a sign of DCIS, commonly seen in DCIS. So, if you have this clustered microcalcification, that is what is the first thing which you should think about. Benign calcifications, you know, popcorn calcification is seen in fibroadenoma, lead pipe, you get fat necrosis. In fat necrosis, broken needle is seen in duct ectasia, teacup is seen in fibrocystic disease. These are the typically benign calcifications. Clustered microcalcifications, I have told you, can be seen in patients with DCIS. Then there was another staging question. So, 3 staging questions. One was from breast. This again was on the lines of the NEET-SS breast staging question which was asked. A lady comes with a 3 centimeter breast lump with ipsilateral axillary lymph nodes and internal mammary lymph nodes. Right. So, T is 2 because more than 2 centimeters. N, there are axillary nodes also and internal mammary. So, this is going to be N3B. And M is 0. So, T2, N3B, M0 is the answer. If the question was only internal mammary but no axillary, then it would have been T2, N2B, M0. But here, because both axillary and internal mammary nodes are there, it will be N3B. So, TIS is ductal carcinoma in situ or Paget's disease. You should know that in the 8th AJCC classification, LCIS is no longer in situ. Lobular carcinoma in situ is no longer in situ cancer. It is not considered as in situ cancer, LCIS. T1 microscopic is again an important definition, less than equal to 1 millimeter. T1, I have already told you, is till 2 centimeters, T2 is 2 to 5, T3 is more than 5. T4A is involvement of chest wall, and pectoralis muscle involvement is not considered as chest wall involvement. T4B is skin involvement, which includes pudiorange, ulceration or satellite nodules. T4C is A plus B, and T4D is inflammatory carcinoma, where more than 1/3 of the breast skin is involved with pudiorange. Again, some new terms which you should know. Isolated tumor cells, if you see in a lymph node, this is a cluster of less than 200 cells. Micrometastasis is a cluster of more than 200 cells or less than 0.2 mm deposit, and macrometastasis is a deposit more than 2 millimeters. A newborn baby with respiratory distress is born with a scaphoid abdomen and the apex beat is pushed to the right. X-ray shows bowel loops within the left hemithorax. What is the next best management? So, this is typically a case of congenital diaphragmatic hernia. This is a case of congenital diaphragmatic hernia. And you know congenital diaphragmatic hernia, the most common one is Bokdalic. Bokdalic is left posterolateral, right? That is why there are bowel loops in the left hemithorax. The apex beat is shifted to the right. In such a patient, you know that bag and mask ventilation is contraindicated. ICT should not be inserted, you can injure the bowel. Immediate surgery you will not do, you will first stabilize the patient. Bag and mask is not done. So, we do a nasogastric tube insertion and we stabilize the patient first. You can see here that there are bowel loops in the hemithorax, and you also know that pulmonary hypoplasia is the leading cause of death in these patients. Pulmonary hypoplasia is the leading cause of death in patients with congenital diaphragmatic hernia, and later on these patients can also develop pulmonary hypertension, but the most common cause of death is pulmonary hypoplasia. Congenital microcystic pulmonary malformations was noted in a child at 28 weeks with hydrops. So, if the lungs are not developing properly and you have these microcystic pulmonary malformations, you know that steroid administration would help in proper lung maturation and will help in this condition, right. So, in these patients, you will do maternal steroid administration. This was also something which was new, the Currarino syndrome. The Currarino syndrome, they had asked which of the following is included in the Currarino syndrome. So, this includes sacral agenesis, anorectal malformation and presacral mass is what is there in Currarino syndrome. So, this was also something new which you should remember for the exam. There were a couple of questions from pediatric surgery which were very straightforward, very simple pediatric surgery questions. One of them was, what is the ideal time to operate a child with an inguinal hernia? We know that children with congenital inguinal hernias have high rate of obstruction and strangulation. There is high rate of obstruction and strangulation, and that is why it should be done as soon as it is noted. So, once you note a patient has an inguinal hernia, you will operate it within 5 to 7 days after working up the child. So, as soon as possible the surgery will be done. A child is brought to you with complaints of pain in the loin. Examination shows a mass in the lumbar region. The mass suddenly disappears as the child passes large amounts of urine. What is the child suffering from? So, this is the typical description of Dietl's crisis. And Dietl's crisis is seen when there is hydronephrosis, usually when there is pelviureteric junction obstruction. So, what happens is when there is obstruction, intermittent obstruction is there. So, when there is intermittent obstruction, the kidney will distend, right? The kidney is going to distend with urine and there will be a palpable low-in mass. So, because of intermittent obstruction here at the pelviureteric junction, the kidney is going to distend with the mass, and once the obstruction is relieved, the mass will settle, and all the collected urine and large quantities of urine are passed. So, as it settles, the low-end mass will settle and large quantities of urine will pass. This is typically known as Dietl's crisis, which is seen in hydronephrosis and in patients with pelviureteric junction obstruction. So, the next question also from pediatric surgery was a relatively straightforward question. You have a 2-year-old child who is brought with complaints of leakage of urine through the umbilicus. What is the probable diagnosis? So, you know, urine coming out through the umbilicus is a sign of a persistent urachus. Urachus is the one which is communicating between the bladder and the umbilicus, and this usually happens when the bladder is full. When there is pressure, then urine can come out through the umbilicus. If it was fecal matter through the umbilicus, then the answer would be persistent vitreointestinal duct. So, fecal matter through umbilicus would be vitreointestinal duct, and Meckel's diverticulum is nothing but a remnant of the, it is the remnant of the vitreointestinal duct. So, here you can see that a communication between the bladder and the umbilicus, that is the persistent urachus. A mother brought a male baby with symptoms of UTI. Ultrasound showed a full bladder, bilateral hydronephrosis, and a keyhole sign. What would be the next best investigation? So, this keyhole sign and hydronephrosis, male patient, male baby, all these are features of posterior urethral valves. And posterior urethral valves, to diagnose, we will do a voiding cystourethrogram. And why we do a voiding cystourethrogram and not a retrograde one is because these are one-way valves. So, if you push and dive from outside, the valves will open up. Only when the child is passing urine, then only the valves become shut, and that's how you can pick up this keyhole sign. Now, posterior urethral valves, you have a Young's classification. Type 1 valves are the most common, and these are mucosal folds which extend antero-inferiorly from the bottom of the verumontanum. Type 2 are rare. These are mucosal folds which along the posterolateral urethral wall. Type 3 is known as Cobb's collar. This is a circular diaphragm with a central opening in the membranous urethra, and it is located below the verumontanum and occurs due to abnormal canalization of the urogenital membrane. Posterior urethral valves, the voiding cystourethrogram or micturating cystourethrogram, MCU, is the investigation of choice, and you will get a keyhole defect on an ultrasound and on micturating cystourethrogram as well. Which of the following is the most common cause of recurrent urinary tract infections in pediatric age group? So, recurrent urinary tract infections in pediatric age group will be because of vesico-ureteric reflux. Vesico-ureteric reflux, is very common in children, and that can give rise to recurrent infections. There are 5 grades of vesico-ureteric reflux which you can see. Majority of the patients are treated just with prophylactic antibiotics. Only in very severe cases of grade 5 UR, where the patient is not responding to prophylactic antibiotics, we can do procedures. And these days we carry out minimally invasive procedures like the sting procedure. Sting procedure is subureteric Teflon injection. So, just inject some Teflon in the subureteric space, and this prevents reflux. This is going to prevent reflux in patients. Again, this was a question which was repeated from the NEET-SS exam. You have a 5-year-old girl with continuous dribbling of urine along with normal voiding pattern. So, a mother gets a child saying that she is leaking urine continuously also, but she can also pass good quantities of urine every now and then. She can hold the urine, she can pass it as well, but continuous dribbling also happens simultaneously, and these are telltale findings of duplication of the ureteric system, right? These are telltale findings of duplication of the ureteric system. And you have the Weigert-Mayer's rule. The Weigert-Mayer rule states that the ureter which is draining the upper pole will open more distally and medially. So, more distally and medially as compared to the ureter draining the middle and the lower pole. And this is Weigert-Mayer's rule, and it usually opens at an ectopic site. In females, it opens in the vagina, which is why there is continuous dribbling, and in males, it usually opens in the urethra. The treatment, of course, is reimplantation of the ectopic ureter. This again was a question which was a new question regarding urethral duplication. Which of the following statements is true? So, urethral duplication is defined when the dorsal urethra is hypoplastic and the ventral urethra is normal. That is when we call urethral duplication. It was just a factual question which you need to remember. A 12-month-old male child is brought with complaints of non-palpable testis on the right side. On local examination, the right scrotal sac is empty and the left testis is palpable. So you have undescended testis. You can see lots of questions from pediatric surgery. So that is what students were saying, that there were lots and lots of questions from congenital disorders, from pediatric surgery disorders, this time in the general surgery part. So this is undescended testis, and undescended testis, if you cannot feel the testis in the inguinal region, then we have to carry out a diagnostic laparoscopy. Diagnostic lap is the investigation of choice then to see an intra-abdominal testis, and so the correct answer here will be examination under anesthesia, which would mean doing a diagnostic laparoscopy to see where the testis is located. A child operated for meningomyelocele presents 3 months later with gait abnormalities, lower limb weakness, pain in the lower back. He has a functional ventriculoperitoneal shunt. So because the clear indicator here is that the child is being operated for meningomyelocele. So in patients who've undergone surgery, the cord fibers can get tethered after a neurosurgical procedure. The cord fibers can get tethered, and that can give rise to gait abnormalities, bladder abnormalities, and constant pain. So this is nothing but a tethered cord which is responsible for the child's symptoms. A 6-month-old baby is brought with a history of vomiting and passing mucus mixed stools with blood. On examination, a palpable mass is felt in the right upper quadrant. What is the preferred investigation for this child? So again, this is regarding bowel obstruction, and these are findings of intersusception. You know, intersusception is telescoping of one bowel loop into the other, and this can occur after 6 months of age. The child is having features of obstruction. Mucus mixed with blood is known as red currant jelly stools. These are known as red currant jelly stools. And the mass being felt in the right upper quadrant is known as the sign of dance. Now, in a child, the investigation of choice for bowel obstruction in a child is ultrasound, whereas in an adult it is contrast-enhanced CT scan. And in patients with intersusception, you will get the donut sign or the target sign. You will get one bowel loop and you will get another bowel loop inside it. This is known as the target sign or the donut sign. In intersusception, this will be seen on ultrasound. Which of the following is the best parameter in the preoperative assessment for cardiopulmonary reserve? So, you must have seen any patient who comes in where you think that the cardiopulmonary reserve is not adequate, right? So, we will always ask them that, can you climb one flight of stairs without becoming breathless? And if they have to undergo surgery, you send them for PAC, and the anesthetist is going to order an exercise tolerance testing, right? So, a treadmill test. If they can't do a treadmill, then you will have to do a DSC, a dobutamine stress echo. So, that will tell us about the cardiopulmonary reserve in these patients. Again, a factual question. This was also a new question. Deficiency of which of these vitamins is implicated in the pathogenesis of congenital diaphragmatic hernia? It is vitamin A. So, this is just a factual question which you should remember. You have a 5-year-old boy who is brought to the emergency room with acute scrotal pain on the left hemiscrotum since 4 hours. What is the next best line of action in this child? So, there is acute scrotal pain, right? Acute scrotal pain, you know, the differential diagnosis are going to be torsion, and there is going to be epididymoorchitis. Now, torsion is a surgical emergency, whereas epididymoorchitis can be managed conservatively. Now, there are clinical signs also which can differentiate the two, like like you have the Pren sign. The Pren sign is if you lift the testis, pain reduces in epididymoitis, but pain increases in torsion. You have the angel sign that the testis is lying horizontally, and the Deming sign. That Deming sign is that in torsion the testis lies at a higher level. Deming sign is when in torsion the testis lies at a higher level. But all these clinical signs have low sensitivity. So you will have to do an ultrasound scrotum with Doppler if it is available. That is what you should do to differentiate between the two conditions. Again, a very straightforward question. What is the ideal time to perform orchidopexy in a patient with undescended testis? This is 6 to 9 months. You know that spontaneous descent can occur till 5 to 6 months. If spontaneous descent does not occur, then we have to carry out orchidopexy as soon as possible. A patient who met with blunt abdominal trauma in a motor vehicle accident was found to have grade 3 right renal trauma. So there is grade 3 right renal injury and there is a minimal urinoma. So because of grade 3 there is urinary extravasation and that is collected there and formed a urinoma. Patient is non-infected, no features of infection. Patient was managed conservatively. On day 12, again the urinoma is persisting, but otherwise the patient is fine. So if the urinoma is persisting, what we should do is we should do DJ stenting, right? So this is grade 3, I've told you, injury was there. So you can see here grade 1 is when there is hematuria, there can be hematuria. Grade 2 is when there is a hematoma or laceration. 3 is when there is laceration. Grade 4 is when there is urinary leak or there is vascular injury. Now, if there is a urinoma which is there, if the urinoma is non-infected like in this patient, we should put in DJ stents, and DJ stents would just act as a low resistance passage and the patient will be able to pass that or the urinoma will resolve. But if it is an infected urinoma, then we need to drain it. We do percutaneous drainage using a pigtail catheter. Then we do percutaneous drainage using a pigtail catheter in such patients. A postoperative patient after a free flap reconstruction, so there has been a flap reconstruction, is found to have an arterial block. What are the features of arterial compromise in a flap? This I have covered in the plastic surgery modules. So if there is arterial compromise versus venous compromise in a flap, the flap will be cold in arterial, warm in venous. It will be flaccid in arterial. There will be congestion or it will be turgid in venous. There will be delayed capillary refill, here it will be quick refill, and if you do a pin prick, there will be decreased blood flow, here there will be brisk blood flow if there is a venous compromise. So the flap will be cold and flaccid if there is an arterial compromise in a flap. Which of the following hepatic segments are not resected in right hepatectomy? So right hepatectomy, you know that, so you have 4A, 2, 3, 4B, 5, 6, 7, 8, and this is the middle hepatic vein which is dividing the liver into right and left hemilivers. So if according to the Brisbane classification of liver resection, if you have to do right hepatectomy, it is going to be 5, 6, 7, 8, right? So 4 is not included. If you have to do left hepatectomy, it is going to be 2, 3, 4A, 4B. If you want to do extended right, the new name is right trisectorectomy, right trisectorectomy. Then it is going to be 5, 6, 7, 8, 4A, 4B. Okay. And if you want to do left trisectorectomy, if you want to do left trisectorectomy, it is going to be 2, 3, 4A, 4B, 5 and 8. So that is left trisectorectomy. This is what I've just told you. This is the Brisbane classification for liver resection. An 8-year-old boy presents with a midline cervical swelling diagnosed as a sebaceous cyst. If it's been diagnosed as a sebaceous cyst, you have to excise it. Sebaceous cyst, you know, will require excision. What is the ideal treatment for torticollis in a child who's 2 years old? So, neck torticollis in a child who's 2 years old, you need to do surgical release. And the indications for surgical release in torticollis are indications for surgery are if the diagnosis is beyond 1 year of age. So, like in this child, it was at 2 years, it is persisting till 2 years. So, you have to carry out a surgical release. Conservative management will not work. If there is persistent sternocleidomastoid tightness limiting head rotation for more than 12 to 15 months of age, or if there is persistent sternocleidomastoid tightness with progressive hemifacial hypoplasia, these are the indications when we need to carry out surgery in patients with torticollis. What is the most common cause of chylothorax in children? So, chylothorax most commonly is seen with trauma. It is most commonly seen with trauma, and one of the reasons for trauma is post surgery. So, post surgery would be a better option because it can give rise to chylothorax. So, both trauma and surgical trauma can give rise to chylothorax in children. A mass is noted in the gluteal region of the child. It is pushing the rectum. Ultrasound shows a multiloculated cystic and solid mass with calcification. So, this is typical of a sacrococcygeal teratoma, where it is a solid cystic mass which pushes the rectum. This is a sacrococcygeal teratoma, and this needs to be excised. Excision needs to be done. It can also lead to bladder and bowel abnormalities because of the pressure effect, or if it impinges on the nerves. Which of the following is not a cause of intraoperative hypothermia? So, if you are doing peritoneal lavage, it can cause hypothermia. Infusion of cold saline can cause hypothermia. Loss of heat due to radiation can cause hypothermia. Vasoconstriction will not cause hypothermia. It will in fact prevent heat loss. So, vasodilation will lead to hypothermia, not vasoconstriction. What is the biochemical test of choice for the diagnosis of pheochromocytoma? I think so. This was a very easy and straightforward question. The answer was plasma-free metanephrines. Plasma-free metanephrines was the correct answer here. Pheochromocytomas, you know, headache is the most common symptom which is there. Hypertension is the most common sign. So, symptom is headache, sign is hypertension, and hypertension is majority of the times episodic. The screening test is 24-hour urinary VMA or metanephrines. The most sensitive is plasma-free metanephrines. Plasma-free metanephrines is the most sensitive test. Tan brown colored tumor, MRI is the investigation of choice. For imaging, you get the light bulb sign. But if it's an extraadrenal pheochromocytoma or metastasis, then the investigation of choice is a gallium dotatate scan. So, a gallium dotatate scan should be done in such patients. This is the light bulb sign. And the management, you know, it is always first alpha blockade followed by beta blockade. We never do beta blockade first because that can trigger a hypertensive crisis by unopposed alpha action, right. So, always alpha blockade followed by beta blockade. A 13-year-old male comes with cervical lymphadenopathy. FNAC confirms it to be a papillary carcinoma thyroid, for which total thyroidectomy and neck dissection were done. What is the next immediate management? So we do a radioiodine scan. We know it is papillary carcinoma thyroid. So we will do a radioiodine scan, and thyroxine therapy is not started till we do the radioiodine scan to look for residual disease or metastasis, right? And earlier patients were made to wait for 4 to 6 weeks before the scan was done, but now we can inject recombinant TSH and we can do the scan early as well. The Masoka classification is used for thymomas. Masoka is used for thymomas. This was asked in the NEET PG exam as well. You should in fact know the Masoka staging. Stage 1 is when it is completely encapsulated. Stage 2A is microscopic invasion through the capsule into the fatty tissue. 2B is macroscopic invasion into the capsule. 3 is macroscopic invasion into adjacent organs. 4A is pleural or pericardial implants, and 4B is hematogenous or lymphogenous metastasis to extrathoracic sites, that is stage 4B. This is the Masoka staging for thymomas. What is the most common metabolic complication in total gastrectomy? This again was asked in the NEET SS exam as well. So we know it is anemia, and most commonly it is iron deficiency anemia. There can be vitamin B12 deficiency as well because of loss of intrinsic factor, but the most common metabolic abnormality is iron deficiency anemia in total gastrectomy patients. This is the same metabolic abnormality which is seen post bariatric surgery also, which is why post bariatric surgery these patients are given supplements of iron, vitamin B12 and calcium. Submandibular lymph node, you know, submental is 1A, submandibular is 1B. So 1A is submental, 1B is submandibular, 2 is upper deep cervical, 3 is middle deep cervical, 4 is lower deep cervical. 5 is posterior triangle, which is the largest group. 6 is the central compartment lymph nodes, and 7 are mediastinal lymph nodes. So this was the NEET SS General Surgery recall. Like I told you, because multiple different sets of general surgery questions are asked, that is why there's a long list of questions. Again, there might be some more which we haven't been able to recall. If we get hold of them, we will conduct another session and post another video regarding them. But please go through these questions now, because general surgery is going to form the main thrust or the main focus of your SS preparation. You should go through these questions and the videos in the Marrow app. Even if you can devote 3 to 4 hours every day, you can finish the videos comfortably in 15 to 20 days time, and along with the Q bank, you will be in a very good position to crack the exam. Thank you.